Good evening and happy Friday, everyone. Welcome to this Royal College of Surgeons of England webinar celebrating LGBTQ+ History Month. Tonight's theme is differential outcomes in cancer care, specifically for LGBT+ patients. My name's Susan Moug, my pronouns are she, her, and I'm chairing this evening. I work as a colorectal or bowel surgeon in Glasgow, and I would like to take this public opportunity to say I am not running for the recently available First Minister of Scotland post. So if you can all stop tweeting and messaging me, I'm not doing it. It'll be my great pleasure to introduce Alison and Stewart and Rhea shortly. But first of all, I'd like to talk a little bit about PRiSM. I have joined PRiSM, I can confirm that. So this is the Pride in Surgery Forum. It started in 2021 with the mission of supporting LGBTQ+ surgeons and future surgeons, but also to improve care for those patients too. So that's very prudent for this evening's conversation. There's more info here, there's more info on the QR code, and there's also more info on the Royal College of Surgeons webpage. You would be very welcome to join us. And the other thing to tell you about, next slide please, is our event on the 16th of June in Manchester out at the college. As you know, we work closely with the college and PRiSM, and we're very, very keen to continue to support surgeons and future surgeons, as I said, so you'd be very welcome to come along. So let's get to the main people and the main event. So if I could ask Alison, Stewart and Rhea to introduce themselves, if we could perhaps start with Rhea.
Sure. Hi, everybody. My name is Rhea. I work in the learning department here at the college, and I am also the chair of the college's LGBTQ+ staff network. So you won't be hearing too much from me today. I'm mostly here to just moderate some of the questions that'll be coming through and just kind of representing the sort of staff side of things from the from our LGBT network.
Great, thank you for coming. And that's a good point. Questions, please post them as we go along. We may answer them as we go along, but certainly there'll be opportunities at the end. So now to the most important people on this webinar. Sorry, Rhea. Stewart and Alison. Alison, if I can get you to introduce yourself first of all.
Yeah, so my name is Alison Berner, my pronouns are she and her, and I am an academic clinical lecturer and specialty trainee in medical oncology at Barts Cancer Institute, and also a specialty doctor in adult gender identity at the Gender Identity Clinic in London, part of the Tavistock and Portman.
Fabulous. Stewart.
Hi everyone, my name is Stewart Callahan. I use they, them, and I'm the founder and chief executive of this, which is the UK's only LGBTIQ+ cancer charity, and I have CML myself. I have chronic myeloid leukemia.
Well, you're both very welcome. So if we could start with the presentation first of all. So next slide, please.
So I'll just sort of introduce a little bit about who I am in the charity and how it got started, just for a bit of context, and then Alison will sort of take us through some other slides and we'll sort of ping pong the talk back and forth. But the charity exists because I realized firsthand that there was a lack of provision for people in our community, and this came from everything from cancer centres, talking through treatments, making plans, and generally feeling quite unsupported regardless of which cancer centre I went to across the country. So we very quickly pulled something together that now provides peer support, education, and also unique resources that support the community. Next slide, please. So we'll start with communication. Next slide.
You'll have to apologise for us for the delay. We're doing a bit of Boris here, I'm afraid, folks.
By way of a quick recap, for most people, I'm sure this will be a very easy revision, but we just wanted to go over some simple points about communication that comes up when we talk about supporting our community. So one of the key ones that's obviously bandied around at the moment is pronouns, and obviously the first thing to point out is pronouns are a standard feature of our language and we use them to replace a noun in a sentence, and this is where you typically see he, him, she, her, they, them. But obviously when we think about reinforcing and supporting someone's gender, it's really important to be using the right ones at the right time and with the right people. And although some people get a bit confused by singular they, it's very common in our language, especially when we're being gender neutral or we don't know the person's gender. And for any sort of buffs in English language, they'll know that singular they is actually older than singular the you. So when we think about this as well, it's important to think about patients. when we're talking to them, but also the notes we're making, the referrals, and how we speak to our colleagues as well, so that we're upholding someone's identity throughout and not just sort of placating them in that consultation. And when you see them written, you would typically see it as object/subject in a grammatical form. So this is how you get your he, him, she, her, they, them. And you will sometimes see people who have multiple, as you can see in Ria's name just on here on the digital call. So you'll see she, they.
And just to note that some people, you know, feel a bit clunky about asking these things and don't like to ask things like pronouns outright. Just that I've found a real tip that when we're asking people, you know, sometimes we might say, what would you like me to call you? If we say, how would you like me to refer to you? That encompasses name and pronouns and really opens the door. So if you feel like you might be misinterpreted, your patient, you know, you perhaps assume, and we should be careful with assumptions, that your patient might get a bit confused if you start asking about pronouns. Just asking how you would like to refer to someone can feel a bit smoother, though a lot of people get exactly what you mean and they'll tell you what pronouns.
It's also worth noting, if I may jump in, about multiple pronouns. If you do see someone who uses, so my pronouns are she, they, and that for me means either is fine. In a more sort of granular sense, it means that sometimes I feel more, sometimes I feel like a little bit more of a she, sometimes I feel like a little bit more of a they. It kind of changes from day to day, but I don't expect other people to keep up with me. So really, it just kind of means if you see anybody with this sort of thing, it basically just means either is fine, and if you use a mix or whatever, that's great.
Amazing. So next slide. So to really hit home this point about pronouns, there is a patient video that we want to share with you. So those of you who are using a Mac may not see the video, but you'll be able to hear the audio, and that's the important part. So you'll hear from Kian, who's a young patient, and talks about the negative experience of when things go wrong and also ways that things can also go right. So some points to notice there is the importance of pronouns to the individual, but also these opportunities for disclosure. So being able to fill out a form in a way that feels appropriate. So that's where we're thinking about, is our monitoring appropriate? And does it also include non-binary identity? Does it allow people to tell us who they are so we can understand when it may potentially not align with what's on the patient record and what we can do as additional steps to help? And this can include making sure that our notes are actually reaffirming who that person is, because we have to be thinking about that patient also potentially seeing these notes as well. So obviously we can be limited when we're thinking about pathways and referrals and the things we have to do in certain ways, and especially when it's aligned to a sex marker, but there's nothing stopping us supporting the patient in how they identify, especially when we think about, as I said, those letters sometimes being duplicated and sent home. So next slide. But mistakes do happen, and no one is impervious. Sometimes it can happen even between best of friends, and it's about how we recover that's the important thing. So I set this up a couple of years ago, just thinking about when my friends and I sometimes make a slip up and we accidentally misgender, and you recover in the moment and how to move forwards, and spoke to a bunch of different people about what works for them. And we settled on this AA-CC system. So A is sort of outwards, C is a little bit more reflexive. So the first thing you do if you make a mistake is you acknowledge you made a mistake. You don't have to oversell the apology. That sometimes makes it a bit awkward, but just point out, okay, yeah, I think I got that wrong. And then next thing, ask if this is an opportunity just to make sure you've got all the information you need and make sure you're going to do this properly. They may have already corrected you with the correct pronouns, but if not, it's a really good time to check. And then it's your work, then it's on you. So then you need to start correcting yourself and demonstrate your changed behavior and do it properly so that the patient understands that you have listened and understood. And lastly, commit to it. make sure that they're not having to correct you every single time, because then that really shows that it's not something that you're taking on board properly. Next slide. So as I said, this is something I put together a good couple of years ago, and then when we were building our webinars for something else, we stumbled upon this podcast, and you can see that system working naturally in conversation. If we play the video. So in that video or audio, so for those of us who just got the audio there, it may have sounded weird, but it's because it was some fun creative editing that we unfortunately missed out on. But those on Windows computers will have seen it. And you can see that that recovery is what matters, that honest intention and that fast recovery, in a way to show that it's not super awkward. And as long as it's done with the right intention, you can absolutely move past those small mistakes. Next slide.
So now we're going to move on to talk about disclosure, and that's how you share these parts of your identity with other people, and how you encourage the patients that you're seeing to share those with you. And when we titled this, and I think you missed the title slide at the beginning, it was about bringing your whole self to surgery, because actually although this has been billed as talking about, and this is our specialty, about LGBTQ cancer care within surgery, actually there's lots of space for this throughout surgery. It's not just our cancer patients that are LGBTQ, and actually encouraging disclosure from everyone that we see can actually add to improvements in their patient experience. There's nothing special about asking your cancer patients their pronouns and not anybody else. And it's also about bringing yourself and disclosing sometimes delicate parts of your identity with other staff members, and sometimes with your patients as well, where it's appropriate, because actually that point of connection can help them feel more comfortable. It might allow you to take a more thorough history. It might just help them feel more confident and comfortable in the moment. Next slide. So we've over the years, there's been a lot of research that cues in the environment are really helpful to make people feel safe and comfortable. And the rainbow has been used for a very long time. Obviously, it features in PRiSM, it features everywhere during the month, though of course we now face the challenge that it was used extensively, for very good reason, to support the NHS during COVID. So the rainbow is not what it was. It does now need to be accompanied by, very clear messaging that it's LGBTQ related. And many of you will have seen things like the rainbow badge around, and there's also a trans flag version of the rainbow badge. That's the trans flag there you can see in the blue, pink and white, for those of you not familiar. And there are other more specific flags for other identities. And encouraging these things to be kind of put out in the waiting space does really help. You can wear a lanyard yourself if you're allowed to wear a lanyard. You can do things with your own kind of pin badges, and indeed putting your pronouns on your pin and putting it in your email signature and places like that is, again, that's about an environment, even if it's the virtual environment that you create. However, we do have to be careful, because if we're putting these signals out there that people should feel safe, then we need to make sure that that space is safe to disclose. So it does need to be accompanied by a level of awareness and a level of training. So going out into the environment where you are, if you are championing and you are making sure that these posters are up and out there, it's also about testing the water to see where your colleagues are at in terms of their training, awareness and attitudes, and actually perhaps where necessary trying to introduce that. Now, for people who are on the call that are part of the LGBTQ community, I'm sure you feel the burden of trying to bring that on, and perhaps, sometimes even struggling to feel safe to disclose in that place where you are, and we'll touch on some sort of ways to do that more towards the end. Next slide. Also, if someone does share that information with you, it's really important that you are kind of asking exactly how they want that to be recorded. So can you share that information with people within the care team, outside of the immediate care team, who of their friends, family, chosen family knows about the information that they're sharing with you? So if someone's quite early in exploring their gender identity and prefers that you use they, them, but actually their family is perhaps not aware of that, then you might need to know that in the room. And particularly this around making requests. So things like imaging requests, which obviously really commonly you need to use. So inform people that actually it'd be really helpful if you might be able to put the fact that their gender is different to the sex assigned at birth on a imaging form, if it's going to make it clearer to the radiologist. But actually, if someone declines that request, then someone declines that request, and it's really important. And the GRC, which stands for Gender Recognition Certificate, which not everybody will have, does put in particular legal protections. So it's really important to be aware of that outside and above our kind of own duty of kind of confidentiality. Next slide.
Hi, yeah, back to me. So, single cancer pathway. So this is an interesting model that was put together by Wales Cancer Network that is a really simple pathway of what the patient should be going through in order to get a timely diagnosis. So, next slide. And I really like this model because it's a really holistic way of viewing that patient experience, from the patient interval where they're driving the care, and then we have the primary care interval where they're in their GPs and that's happening, and then you also have your secondary care interval. So this is obviously when they're in that secondary care environment. Next slide. But it's important to note that there are multiple different areas where this might break down. So in patient interval, you've got the aspect of not enough LGBT-based information outside of sexual health, so understanding where things might overlap. In primary care, we've got delayed attendance to primary care and sometimes difficulty getting people right on the right pathway, especially if they're trans and we don't know that. But also in secondary care, there's a bunch of things we have to take into consideration. So I'm just going to run through a quick bullet point list of some of them, and we can discuss them more towards the end of the talk. But a key one to be thinking about is sometimes a patient's treatment-related goals may differ. So this can be related to, especially oncology, which is where we think about a lot, but thinking about the fact that it may be related to sexual function, quality of life, bodily autonomy, fertility, things like that, that we sometimes go with assumptions of what we think are the optimal outcomes, but thinking about checking in with the patient about what's most important to them. And we have some case studies that align with this. And then the other thing to think about, especially with that, is trans patients who may want to prioritize their transition. So when we think about cancer, this is something that comes up a lot when we think about the potential interplay between gender-affirming hormones and cancers, and thinking about how this needs to be an open discussion, which is something that Alison has set up a service for that we'll also describe. But also, again, that psychosexual impacts and wellness. I remember speaking to a urological surgeon about this and asking him what would be the most useful thing for people to know as part of the referral. And he said gender identity and sexual orientation, just so he can have an open conversation about that expectation about what comes out at the end of surgery. And this specifically was in urology, and thinking about how he can best prepare that patient for any changes that might be happening, or going into the surgery thinking about potentially nerve-sparing procedures, things like that that can support the patient's wellness. And if we give a direct example, it, for example, could be the removal of the prostate and how this will affect someone's sex life, whether they're the active partner or even the passive in anal sex. And then also thinking about community-aware support. So when patients are going through this and the lack of tailored support, there is support available from us as a charity. So we provide peer support for patients, and they're more than welcome to get in touch. And Alison has her UCAT service we'll touch on later. But just appreciating that sometimes sending someone out the door and saying you'll find it on your own isn't always the case. So thinking about good signposting, or if there are any particular navigator roles that are available that we can plug them into. And of course, patient-professional relationship is super important, especially for LGBT or any minority patient that sometimes feels like the system isn't necessarily working for them. Okay, next slide. So on to those case studies I alluded to. So next slide, please. So we'll be starting with a video. So just for a small introduction, this is Charles. Charles came to my charity looking for peer support originally, and came and was diagnosed with multiple forms of cancer over their lifetime, actually. So they had blood cancers, and then they've also had breast cancers. And it was at the point where they had breast cancer that they came to us and had the very difficult position whereby the surgeons had presumed that Charles, who was assigned female at birth and at the time still had breast tissue, would want to continue having breasts afterwards and would want a reconstruction. Charles hadn't quite disclosed that they were genderqueer because they weren't sure if it was safe to do so. And as a result was in a difficult position where they actually wanted to remain flat after surgery. They wanted a complete double mastectomy, but the surgeon disagreed and left additional tissue on the chest for when Charles would want a reconstruction, which was obviously against Charles's wishes. So we're just going to hear from Charles in their own words about this, and then we'll reflect on it in a bit. Okay, unfortunately it started partway through. So the bit that you missed at the beginning there, where Charles was talking about an elephant in the room, was actually talking with the surgical team and other healthcare providers in the presence of their husband. So because Charles is registered female at birth and had a husband, people were making the assumption it was a heterosexual couple. And Charles and I have had long conversations about the potential benefit that sometimes has for some patients when they almost go back in the closet to try and expedite their care, but then actually having to almost compartmentalize their identity and therefore not necessarily explain their full wishes, or again, those differences in treatment outcomes that comes as a result. And Charles was in quite a difficult position and very affected by all of this, especially by having tissue left on the chest that they didn't want, and really requested some direct advocacy after attending peer support because they needed help navigating this because they didn't feel like they were being listened to. And this is where Alison got involved and helped Charles reach a resolution. So I wanted to see if you want to come in, Alison.
Yeah, so I think here it was a real difficulty between a sort of understanding from the kind of surgical perspective, the patient's perspective, but also where gender affirming care might feed into that, and actually the fact that there isn't necessarily the desire from a person primarily to see a gender identity service and kind of have gender affirming care always if the gender identity doesn't match the sex they were assigned at birth. But actually then other things can happen in life that mean that suddenly the feelings of a person towards their body changes, their goals change, and actually that is when they need assistance. Unfortunately, the position we're in at the moment is we don't have a system for gender affirming care that is rapid and on demand, and that causes many problems, and that doesn't help with the integration in moments like this, where actually we need to make a decision because there is another priority in the person's healthcare. That means that actually we need to make decisions about things that are in part related to someone's gender and the feelings around their body at a slightly expedited time. Now, that's not to say we should be rushing into things, and certainly there's benefit in between assessments and part of a gender affirming pathway to let people have time. But in the same way we do, for example, patients with a BRCA mutation, where we're talking about a prophylactic mastectomy, and we give people time with a psychology service, and then we allow them to kind of make that decision on what is, the time that is necessary, to get things done and to start thinking about choices when people are at risk. Then we need to really kind of integrate that as part of the whole person. And so it's kind of bringing an understanding in on that, and then ensuring, because obviously we're all aware that we want to support patients to make the right decision and when you're putting someone under the knife, which is something that I don't do, you need to know that that person is fully understanding and is not making a snap decision. And so it's about us trying to integrate that care to give the assurance to the clinician and the person that's holding the scalpel and to the patient, that, you know, that we're supporting them in the best way psychologically with their physical well-being moving forward. And in particular, because time spent feeling that level of dysphoria with your body has impacts on mental health, and we know that mental health has a huge impact on physical health, and I don't think we've still quite got to grips with the numbers on that, but certainly that can have huge then impacts on, you know, down the line. And I have other examples where people's delays in their gender affirming care and the impacts on their mental health certainly have led to poorer cancer outcomes.
Thank you, Alison.
If I may say, there's also a consent issue here. If shared decision making is what we're all supposed to be achieving as surgeons or otherwise, this hasn't happened here at all, is it? That's quite tough to listen to be honest.
Yeah, and it was tough watching Charles be in that difficult position as well, and really wrestling with what we talked about earlier, that disclosure. And there's another clip I have of Charles. There's a full 18-minute interview with Charles for people who are interested on our website. And Charles really goes through the full rigmarole, really, of trying to be heard, but also wrestling with, if I come out as genderqueer, will it work in my favor or against me? And really trying to understand how the system worked for them. But the positive resolution out of this was Charles was able to have support and get a second opinion and have the surgery that they wanted, and now is so much happier and living a wonderful, healthy, happy life. So there can be some good outcomes, even if there are barriers to get there. Next slide, please. So this patient is another person who's accessed peer support from me, interesting patient, in their 50s and were due for bladder surgery, but also has HIV and also a blood cancer and a family history of prostate cancer. So quite a mixed bag. This obviously led the patient to have quite a heightened worry about their health for anything that was going wrong at the time, and they were having some issues with retaining function of their bladder, and this had been meant at one point they were self-catheterizing quite regularly. So they were obviously not in a great place, and they had struggled to be seen and taken seriously, and eventually were put in for bladder surgery. The problem was that this patient wasn't actually being spoken to in a way that they felt that they could get the answers they wanted, and because they were between multiple different teams, they felt like there wasn't a central place to have joined up conversations about their care, and as a result, they ended up calling or emailing me in a bit of a frenzy 2 days before their surgery because they felt like their questions hadn't been answered and they didn't feel prepared for surgery. I did my best as I could to push them back into the right channels for how they could get answers and give them tips on how to get those responses. But when I checked in with them a couple of weeks later, ultimately the patient didn't go for surgery because they didn't have answers relating to not only the surgery itself, but also how it would affect their sexual wellness. And is thinking about erectile dysfunction, and this can sometimes be a more pronounced consideration for men who have sex with men or men who engage in anal sex, because you need a firmer erection in order to engage in anal sex than you do in vaginal sex. So it's these open conversations you sometimes have to have with the patient so you can describe to them and have them describe back to you how the functional impacts may be, and also the kind of sex they want to have, and if there is a way to plan a fulfilling life moving forwards, and what is their priority and other people we can bring into their care, especially when patients are at a point where they don't attend the surgery they need. And to my knowledge, this patient still hasn't gone for that surgery and not sure what their path forward will be. Next slide. This is another one I wanted to put in because, especially when we talk about sexual wellness, I think we talk about people registered male at birth quite often, and this is an interesting case of someone registered female at birth in the sexual wellness context. So this is a non-binary person registered female at birth, and they are going under a proctectomy for Crohn's disease, and has shared their experience, especially in the sort of patient way where they talk about it being a Barbie butt, and sort of trying to get their head around what this is for them. And the interesting thing about this patient is anal sex and pleasure is incredibly important to this person's sexual function and also identity. And it's something that they have shared openly with in our peer support groups in quite an extensive level, to be honest. about their fear about losing something that for them is quite integral to their personhood and their connection sexually and intimately with others. And the fact that in those spaces, this patient is sometimes not being understood or respected in case of sexual wellness because they prefer anal sex rather than vaginal, and also that this patient is non-binary. So they've also find that the language used sometimes perioperatively is a lot about, strong young woman, there's a lot of pink robes, there's a lot of hyperfemininity that's sometimes put on patients as an attempt to lean into a restorative language. But for those patients who don't identify in that way, it can actually be an even bigger barrier to feeling comfortable and safe in those spaces and feel like their identity is being understood. So I just wanted to point out that one, really just to ruminate on the aspect of we shouldn't be making assumptions about someone's sexual function, identity or wellness, and checking with them about what works for them and what their goals are after surgery.
And I think I'd want to add just to those. Oh, sorry, there's a delay, so I'm talking over you, Susan. I think there's something around there about not making assumptions based on age as well, although it's not so frank in those cases. Sometimes we really see that, and actually there are people who feel like they come much more into their sexual prime later in life. And certainly in the case of this person, they were really able to advocate for that being an important part of their life and are quite vocal, but not everybody will feel that way. And that just sort of leans into the fact that regardless if we're talking about gender identity or sexual orientation, that actually there may be aspects, it may not be sexual function, it may be something very different, that the person just may not have that extroverted character to be able to put forward and say, no, stop doing that. This is what's important to me. And that might be around chosen family and who you contact, for example. You don't know someone's individual family dynamics, or there'll be aspects of identity, all sorts of aspects of identity that people may not feel strong enough to be an advocate for unless you lean into it and ask and pick up on those subtle cues and leave space for it.
Yeah, I think you're right. I was going to say there was a survey published last year or the year before led by a patient looking at how we as surgeons, because I'm feeling bad for surgeons now, how surgeons actually discuss sexual function and anything regularly as part of the colorectal kind of context of complications. And funnily enough, you won't be surprised to know it was poor, it was low. So I think if you've got that generally, never mind being much more specific about the patient's needs, that probably means we're even worse at that. Feel free for anyone who's listening to disagree with me.
One final one. So I just wanted to add in another patient I've remembered who went for surgery. So similar region, so in sort of the anal area. And when the patient was being spoken to, it was a day surgery, and the surgeon was being very good in saying, like, what kind of sex do you have, recovery, potential for there to be scarring, things like that. But they were doing this conversation in the seats that go and wait in for day surgery. So again, just remembering that curtain isn't a sound barrier, and this surgeon was incredibly friendly in saying, do you have anal sex? Do you do fisting? All these things in this way to try and be as sort of inclusive as possible. But then remember, is that patient going to talk about that stuff right there in that moment, or do you want to find another opportunity that gives them a bit more privacy to potentially tell you what they're into, what they're up to?
And where do we learn that curtain? Where does that curtain learning thing come from, that we think it's impenetrable, no one can hear through it? We're all guilty.
That's a space for kind of some higher level work within all of our organisations to advocate for space. Space would be great to try to work on all this stuff. Next slide.
Either that or a magic curtain that actually does block sound.
Yeah, it'd be great if we all worked on Grey's Anatomy with those lovely glass walls between the beds.
Yeah. Nice.
Yeah, next case, please. So this last case really again speaks to that intersection between sort of general care out there in the wider world and specialist gender affirming care. So this was a lady who was a trans woman who was treated for prostate cancer. She had quite a lot of treatment, so she had a radical prostatectomy and pelvic radiation, and one of her goals was future genital reconstructive surgery, but actually she was being troubled by urethral stenosis and lower urinary tract symptoms following her radiotherapy, and she was recently started on hormones, and she was quite rightly referred to the urologist, but there was some reluctance around dilating the urethra because of concerns about future future surgeries. But again, there was an assumption about what might or might not be right, and no one had actually contacted a surgeon because she hadn't yet been referred, but nobody had done the phone a friend to say, actually, is that right? Or should we actually be doing that? And in fact, it's really important to dilate in that sense, because actually you might cause more problems to her future surgery if you allow the urethra to become stenosed, and also her goals may be totally out the window if she ends up with a suprapubic catheter. So again, it's just saying that sometimes, although we're all very busy, it's actually exploring where the patient is in the gender affirming pathway. Could we contact someone, may not even be the right person, but chase the butterfly and go that little bit of extra mile to find out if that is exactly the right thing that we should be doing. And there is obviously also the reverse of that. So it's actually not assuming that gender affirming care is a linear pathway that some people might imagine. It's a menu of options that people choose from. And so we do sometimes see the reverse, that people assume that people might want a hysterectomy, or want to have ovaries removed, or things like that. And that's not the case. So again, it's about that bespoke level of care. Next slide. So that leads me on to UCATS, which is a service available for you to refer to for your complex cancer cases, where patients are gender diverse or trans or somewhere under that umbrella, and you think that there is an intersection between their gender affirming care or their identity and the care that you are offering or that will be on offer to them. I'd rather people referred and we told them, actually, this is really simple, we don't need to see them, than nobody referred at all. And it's a hybrid MDT in clinic. So essentially the person gets a virtual appointment for about an hour, though we can make that longer. And they dial in, but the clinicians involved in their care can also dial in. So not just a treating surgeon or an oncologist, but GP, their gender identity clinic clinicians, anyone that was really relevant to piecing that all together. And the reason this idea came about is that during the last 6 years that I've worked at the GIC, a frequent kind of task of mine has been just trying to join up people's oncology and gender identity care. And certainly before I started working there, there was one case in particular where a person was getting batted back and forth while there was a decision made about whether they could continue their hormones in the context of hormone receptor positive breast cancer. And without going into the minutiae, there were all sorts of things to do with, will this cancer respond to testosterone? Will it respond if this is broken down to estrogen? What are we doing about risk? Where is the evidence? And so what we're able to do is appraise the best evidence and put that to the patient along with the views of their specialists. So we can't have, myself and colleagues in it, we don't have every specialist knowledge about every cancer. We don't operate ourselves, but we can dial the right people in, or if those people aren't available to dial in, we can seek that information and come back. And it's not being left upon the patient to seek that information, with perhaps them sometimes being asked, well, okay, the patient is the expert in their own identity, but they may not be the medical expert in their gender affirming care. They're an expert in what they want, but there are aspects that we can't put that burden of education onto them. So yeah, we offer an appointment, we do the review. The patient can be reviewed as many times as they like at the moment. We may have to change that depending on future kind of availability and commissioning. And patients can also self-refer. So there are cases where people actually might not want to disclose to various people, and we can choose where that correspondence goes to as well. We can also signpost out. We frequently signpost out to Live Through This, for example, but other resources as well. So note down the email, and we will have a shiny new website coming very soon.
And can I, Alison, this is brilliant. So can I ask Scottish patients?
We're taking everyone, so you don't have to be. You just have to be on our little wee islands. You don't need to be under NHS care. You can refer in if you're private as well. You just need to be eligible for some sort of NHS care that we can put in a number. But we just want to get this service out there and launched and running and help people. And the spectrum of different challenges that people have faced and cancer types and everything has been huge that we've even seen to date. And even in those that I've dealt with at the GI, I see that before UCATs came into existence. And the more we're able to do this, the more we can start to join up care and collect data and put a case for where healthcare needs might be. Because something we haven't mentioned in the course of this webinar is that we don't currently routinely monitor for gender identity and trans status, really routinely in healthcare at all. We don't monitor it for it in the cancer registry. And so where this population's outcomes are poorer, we don't actually know. And so that's why we talk a lot about disclosure, how we can encourage disclosure so that people trust to give us that information. And then as that starts to happen, we can start to make the case to record it better and then improve health outcomes.
Brilliant, absolutely brilliant. Do you think some of the questions you get would probably be quite straightforward? I know you talked about the range, but there must be some that are embarrassingly straightforward that you think locally or surgically we don't have the knowledge just to answer quickly and give the patient the quick reassurance?
We're hoping to sort of build a quick toolbox, if you see what I mean, by the things that we get asked that we now realise people don't know. But there are others where actually the research isn't great, because we have challenges about research in cancer in this community because it's geographically dispersed, risks are different depending on local hormone protocols, things like that. So actually it does require the patient to be in the room with all of the experts giving their information for it to be truly informed consent. So that's what we're trying to do.
May I ask you a question about research?
Oh, yes.
Okay, so research generally, this is my opinion, no one else's, that there's a lot of mainstream people included in recruitment for UK research, if I may use that term. So female research, particularly menopause, hormonal, that sort of stuff, you then drop down into less researched. Then you go into LGBTQ positive research, or even further down. And I'm assuming transition services are even, forgive me, lower funded, recruited, supported. Is that a fair comment?
It's an incredibly fair comment, and a lot of the work that we have done has been unfunded, and actually funding allocation is a huge area that myself and Stewart have highlighted in things that we have written, because I'm particularly passionate because it's a small population, but it's a significant population. The trans population in the UK around about 1%. According to data, but we think it's much higher if you actually include a wider spectrum of people who are who would classify themselves as gender diverse individuals. I think just because a population is small doesn't mean we should ignore it. There's lots of very rare diseases we learn about at medical school that we will never see. You're definitely going to meet a trans person on your tube journey. So that's one thing. There's also a hell of a lot we can learn. We can learn in the cis population to apply to the trans population, the trans population to apply for the cis population. No work is an island. And so I make the case for this frequently. Certainly you've mentioned menopause, but there's a huge range of hormonal variation in the general population that actually we don't take into account of, and that's actually an area I'm interested in. So I'm interested in sex differences in cancer more broadly as well, and the role of hormones in non-sex related cancers, because I think that's hugely important. And so we make a big case to try to get more of this work funded, and part of that is also making sure that it's published in well-recognized journals, because that then fires the whole thing up as well. But it also needs to be done well, and so something that Stewart's involved extensively in, and a lot of the research that I do, and actually that I would say we do together, is this co-production. So making sure that you're doing the work that the population feels is important to them in a way that is important to them. And I say the population because this applies to any work you're doing. You need to ask people what they want and what is important to them, not just what's an interesting question to you, the researcher, or as a clinical challenge. It might be a clinical challenge, but it might not feel relevant to the patient at all. And so that co-production is key. I think there's a huge drive for more of this sort of work. I think the funding landscape will change and is changing, and that's really nice, but it's so hard to get your pilot data because we're not collecting the information. I'm seeing huge nods from Rhea and Stewart right now.
Yeah, and
I feel a database coming on.
Yeah, and I want to add a quick point on the aspect of disclosure rates that we currently have. So obviously the census was slightly underrepresentative if you compare it to NHS disclosure rates on things like the GP patient survey, which is the best survey we have with sexual orientation and gender identity data. And I have asked Amanda Pritchard directly why we don't do better monitoring. I've been told that we can just make do with the surveys, which I don't think is good enough, if I'm being entirely honest and frank. But we have to think about it also in the aspect of generations. So if we think about it as if we look at the data, there's 0.8% in GP patient survey who identify themselves as trans, but in 16 to 24-year-olds, that goes up to 2.2%. So it's a really big jump. And then we also see a similar thing in sexual orientation, where it's about 5% across all ages. But if you just look at young people, it's about 12% who identify as LGB or other. So, and also bisexuality massively increasing over time as well. There will always be a ceiling effect. It's not like everybody's going to end up being LGBT, but it's important to note that actually, I know we can hope, but it's important to note that, you know, patients who, let's be honest, that high percentage is going to be in every generation, but we are going to see patients coming through healthcare who are much more likely to disclose and demand a level of personalised care that we say we offer within the NHS, and really want their identity to be pulled into this and be able to speak about frankly, and as we've touched on before, a shared care plan as well.
I know, I'm just thinking here, embarrassingly, for me to not know this answer, there's a national database on outcomes for bowel cancer. You know, we're very well established across England and Wales. I couldn't tell you where we are with LGBTQ positive in that at all. And if there's a big push for age related, so younger people are the highest growing or biggest percentage of people now getting bowel cancer. Not that they're anywhere near the others, but they are increasing, and we're looking as why that is. What if you're gay? I couldn't tell you what your risk factors are at all. And if lifestyle's important, you would think maybe something could be explored.
Yeah. And it's the same in breast cancer as well. So I was asked at a conference to help look at the National Breast Cancer Audit for the same reason that we don't have sexual orientation, gender identity. It's just starting to come into some of the US registries, and there is some signal of differing cancer incidence and outcome rates, but there it's where trans status has been coded and sex assigned at birth wasn't always available, so you can't work out where that's coming from, and there's no risk factor information. So we're slowly getting there, but it really needs it to change, because we're not, even if we change things now, we're not going to have this data for 20 years, or good data on a lot of this stuff. So
very true.
We need to do it
and
now.
I was looking. Good point. Let's do it. And the other point, obviously, is screening programs. The uptake for LGBTQ positive, whether that's discrimination or what, the screening program uptakes are pretty poor. And I was looking at bowel cancer again tonight, just because that's all I do with my life. And they don't have any comment whatsoever on gender identity, status, nothing there. What's your thoughts on screening programs, Stuart, Alison?
So lots of them, I'll be honest.
Yeah, we're laughing because it's a lot of what we do.
I'll start with bowel and then sort of branch out. But so the interesting thing about bowel, I think, is because we send the kit out to everybody, we think, oh, it's an inclusive service, we don't have to worry about it. But what then if someone has an appointment where they need to be pulled in because of identified blood in the stool, and then thinking about if that person's trans, and are they actually being told that it's a safe space to disrobe from the waist down? You know, it's these things where we're not thinking about things all the way through. So what's the likelihood of that person attending? And then when we think about the programs that are based on having a female marker for automatic invitation, so things like cervical screening and breast, although breast, obviously you can have an indeterminate sex marker and be invited as well. But it's really important to note that we're placing additional burden on the patient to drive their care, to know when they're eligible, and have to also disclose in order to access that service, which is theirs for them to gain. And we've found as well that the messaging that currently exists in these campaigns that are sort of used regularly every year don't really speak to the community. And they want to feel people who look like them, relate to them, and can share their experience. They don't want the standard messaging that's just not hitting the right mark. And although there are updates due for cervical screening to allow opt-in for trans-masculine people registered with the male marker, again, details on this are very slim. We don't really know how or when it's coming out just yet. And if we think about the breast screening program, there is no pathway for a person with a male marker to go into an asympto pathway for routine screening. So for example, if a trans man hasn't had top surgery in the age categories, they would have to go into a symptomatic male clinic, which obviously isn't the right referral. So then it takes up a clinic space in that one. So it's all these broken systems that really, they're trying to be fixed, but even the fixes unfortunately feel like band-aids. Really, there needs to be a full restructure of the systems. And one of the things that would be really fantastic is if patient records could have a sex registered birth marker and a separate gender marker. So then we would be able to know how to refer to the patient if there was a mismatch between the two, if they were trans, and we would potentially know some anatomy that may have been present at birth, so we can think about the right pathways of care.
Yeah, you mentioned the well, one of your case studies, the trans woman who had prostate cancer, and that's an interesting one. It's you know, speaking about screening and stuff like that. Like speaking personally, my markers are all listed as female on all my NHS documents. I get letters telling me to go in for for cervical screening and stuff like that every once in a while, and those go right in the bin. And and it's an interesting communications thing though, because to be honest, like, you know, obviously, like, I'm not unaware of the fact that I have a prostate, but at the same time, if a doctor asked me a question about my, like, just like about like prostate cancer or prostate cancer screening or something like that, I would be quite offended probably, because I would assume they haven't actually looked at my file. They've just looked at me. And there's an interesting kind of communication hurdle there of kind of getting across these things, because a lot of the cancers that, you know, a lot of types of cancer are like inherently gendered, and what we assume that, you know, the kind of people that are getting X or whatever type of cancer.
And it's really that there's so many layers like into that, as you say. There's the inaccurate data we're getting because we're inviting people who actually, you know, don't have a cervix for screening. In prostate cancer in particular, that, you know, we know that the risk is lower as a result of gender affirming hormones, but it's not nothing, and there is a chance that when those cancers do develop, they are more aggressive, but we don't know that for certain. Again, our research is scant. And one of the big barriers to this, you know, I've been speaking to the team at the ICR that are working on targeted prostate cancer screening in the context of genetic risk. And when they have seen trans feminine people, they are unable to, you know, have to have fights with the lab to get a PSA level done. And because the computer says no. And there is so much of these things where a lot of it is computer says no. And I'm like, we're in 2023. And I know it's inconvenient, but if we can put people into space, I think we can change the system for a significant proportion of the population. The problem is that it's not straightforward, and it might have to be a bit bespoke, and people can't be bothered to understand the intricacies. But it's not rocket science. And so a lot of what we do is saying, actually, I know you think your system is fixed, but here is where it's broken, and this is why we know, because there are people who've told us so.
I think your layers is a very good word there. Just while Rhea's maybe checking for some questions from the audience, because we're getting close to finishing actually. It's almost as if the patient has to define themselves, then tell you what that means. Then you have to take into the account the individuality of it. And as doctors, you're trained for pattern recognition. A lot of this stuff is not pattern recognition. So maybe that's why we default to, you know, computer says no. And I'm glad you said if we can get humans into space, because if you said humans on the moon, Alison, I might have had a serious controversial discussion with you about whether we've been on the moon or not. But anyway, Rhea, any questions?
Yes, we have a couple that have come in. One question was about how to, you kind of touched on this a little bit, Alison. There was some comments on how clinicians can encourage patients to advocate for their own care. You kind of talked a bit about kind of, you know, signposting and kind of allowing for you know, the space for people to kind of make their own sort of, you know, choices and whatnot. But how can we encourage other clinicians to kind of empower patients to feel that they're able to take that step?
So we've actually done a little bit of research on this in oncologists, but there's been research done on lots of different healthcare professionals. So we've spoken about space, that's hugely important. We've spoken about external cues, that's really important. It's also about knowing why it's important, and it's about, as a clinician, knowing why it's important, and then also as the patient understanding why it's important. So if the clinician doesn't feel it's important, then they won't ask, and they also won't explain to the patient why it's important that they do ask. Whereas if they know the reason and it's clear, they feel empowered to explain, well, look, I'm asking you this question because this factor about your identity allows me to take the whole of you into account, and I need to sort of talk about who's important to you in your life and the type of sex that you have. So this is why I'm asking you these questions. Or actually, we've seen that, you know, people in this particular group are more likely to have this particular risk factor. This is why I'm asking about it. So, you know, making sure that you're clear, I'm not being inappropriately curious. This is what kind of we know from the data, or this is what we don't know from the data, and this is why we're asking your question. Or actually, this is really just about, I need to get to know you so I can support you better. And I want to give you the chance to let me, you know, to tell me what's important to you. Because it's also about, is your LGBTQ identity important to you? Some people are just like, well, it's just a random fact about me. You know, scroll on. Actually, this other thing is much more important.
Rhea, if I may take the lead here, I've got a text message, obviously anonymous, not about to reveal. The question is, surgical college, you've got a surgical audience. What do you think you would like to get across to us? What could the college and surgeons do for both of you, or the three of you?
I'll jump in as just reflecting on hearing everyone talk about data so much. I think it's such a core principle of what holds us back in our systems, and it's sometimes the hardest thing to explain to patient with their expectation management about what we can do for them when the systems, as Alison said, literally say no. So I think the more vocal push we have for better data, better systems, and it is possible. In Manchester, they've just built a custom build of Epic called Hive that allows them to do this. So it is possible. It just takes time and money, which we know is scarce. But I think that's one of the key things. Really pushing for data is the one. The other one is frank conversations about treatment goals, because they may differ from what we expect. And if we give the person the opportunity to explore those, and as Alison said, in a timely manner, because sometimes we are up against it, but making sure that we give people an opportunity to reflect and tell us what's important for them.
Okay, good. Alison, any comments?
For me, it's okay if you don't know. It's okay if you've got absolutely no experience of this, and, you know, as long as you come in as an open book and are like, I don't know, educate me. Or, you know, the worst thing is, actually, I don't know, or I think I know a bit and I'm way too old to learn, which I hear, you know, or I've got way too much going on to earn. It's really fine not to know. Even if you're part of the LGBTQ community, it's really fine not to know. But it's just being really transparent about that and coming in humble, and just, you know, getting into a new field. We're all going to feel like a medical student again, but that's okay. No one's going to judge you. We're just going to rub through it together and learn from our patients. That's what we're all here to do at the end of the day. They're going to teach us as much as we're going to teach them.
Yeah, that's a lovely comment, actually. Rhea, any thoughts?
Yeah, well, no, I was just thinking about kind of like you kind of mentioned, kind of bringing people with you and bringing people kind of up to speed. I mean, you both talked a lot about sexual health and well-being in this session, but my point is that it's about, like, you know, I think a lot of people will kind of have the view of, you know, sexual health and well-being conversations as being a completely different thing to surgery, as being something that it's just like, why would I need to know about someone's, you know, not just like their sexual orientation, but about, like, you know, how they have sex and whatnot, and what they're, you know, actually what they want from sex and what they want from their sex life. And so I guess the question would be, then how do we kind of bring people along on that journey of, like, encouraging people in care to kind of have these conversations about like not just orientation, but also like kind of the more detailed issues around sexuality.
Yeah, I think you're probably pointing out something that's at the forefront of what should always be, shouldn't it, for every patient. Surgeons need to be better. With that, I think we're coming to the end of the hour. So if I could thank Rhea, thank you very much. If I could thank Stewart, if I could thank Alison. It's been a pleasure listening to you all. I've learned tons. And well, let's keep in touch to see what we can do. I'm sure we can change the world. Thank you very much. Have a nice night, everyone.
Thanks so much for having us.
Thanks, everyone.
Take care, everyone. Bye.